Thank you, everyone. So my background is that I'm a medical oncologist. I focus on bringing new drugs in rare cancers, and that's so it was somewhat odd or was a little bit strange when when my wife and I had a son who was born with severe VWD. But it was also like a moment in time where we felt that this was, all the lessons we had learned in medical school and in everyday struggles that we do to bring, new drugs for cancers, especially for rare cancers, to take all that lessons and to implement it here to bring new therapies for severe VWD. So that's sort of the work that we've been building together with Jeanette and others. And this movement is growing. There is now people from across the world who are here today coming together. We're building a consensus. We're building a medical and scientific advisory board to really bring the best minds and the best researchers and the best clinicians together under one roof to really problem solve and try to move the field forward. But one key thing that if there's anything I can tell you is that, bringing new drugs in any disease is extremely challenging. So whether it's blood pressure, whether it's cholesterol, whatever it is, it's actually the burden that the FDA and the EMA sets on people is really high. It's extremely challenging to do this in rare diseases and rare cancers. So severe VWD is even more harder to do than for the common diseases that we all face. The only way to move things forward is from a patient advocacy perspective. This could only be successful if it's a grassroots effort, and that grassroots is right here. So, a lot of people in general, we have this tendency to think, well, somebody else must be thinking about it, somebody else must be working on it, there are people smarter than me who's going to figure that out. The drug companies will figure it out, the doctors will figure it out. That really does not hold true for rare cancers and rare diseases. So every person's voice here is essential, is critical to move this forward. While we know quite a bit about VWD and severe VWD, and of course there are several drugs that have been around for many decades, but to move the needle forward in a really meaningful way, in a transformative way, it really requires a lot more information and data, and that's missing. This field, the honest answer is there's a lot of things that we just don't know, and we need to fill the gaps. And if there is a transformative drug, and you heard a couple of things up here on the podium, there's other things in the works as well. The FDA, when it sits on their table, and they say, should we approve this drug or not, they're not going to be easy on us just because we don't know some of the information or because it's a rare disease. The standards that they set to get new drug approval is just as rigorous. So my point is that we all have lots of information. Each one of our stories is extraordinarily important. And we cannot move anything forward unless we put this in a scientific way. So for the last 2.5, more than that, Jeanette, Chrissy, Jonna, Alice have been tirelessly working to build up a registry. And this registry is essentially an opportunity to give your voice, your experience as a patient. And we know that there's no one single experience for VWD patients, severe VWD. This is a heterogeneous disease, so everybody's voice is extremely critical. So there's one thing you can do, please register. It costs nothing. There's a registration at 3 p.m. in Hall F room. You just need to sign up, and Jonna is going to be there. And every person should try to get into this and try to understand what this registry is, that your data is safe, and that we will use this in a thoughtful, judicious, in the most ethical manner to really move this field forward. We're also going to hear about other registry today. Dr. Sidonia is going to talk about a national effort, and we have experts from across the world, from Europe, from France, from Ireland, this is a movement that is going to be unstoppable, and we are going to stop at nothing but to come up with a cure for severe PWD. And this is just the beginning, and this is really a grassroots effort. So with that, thank you. Dr. Sidonio.
All right, so first up is Dr. Sidonio. I really like the attire for the Florida conference. You're looking quite snazzy. I appreciate that. Just so you all know, we have great presentations. They're all going to run 10 minutes. Then we will have across-the-board Q&A. So jot down a note if you have a question you want to ask Dr. Sidonio. We'll do all of them at the end of the session. And please, if you could be very careful, we are going to have 3 of the staff on microphones. If you have a question you want to ask, stand up. Yeah, let's see you guys. These are the people who are going to come to you with the microphones. So if you have a question when we get to that section, please go ahead and raise your hand. They will come to you and be waiting until it's your turn to ask the question, or at least acknowledge you so you know your question is going to get an opportunity to be spoken. All right, so start us off with what's going on with Athenaheim, Dr. Sidonio.
All right, thank you for allowing me to be here. I was telling Chris Walsh that I borrowed this from his wardrobe, so I'm going to talk a little bit about a study that's actually ending, and then some sort of initiative that James and I are pushing forward. So this is, you probably heard, the American Thrombosis and Hemostasis Network. They're working with the CDC to collect surveillance data. This is all de-identified data, and this allows us, again, like was just mentioned, we have severe diseases. It allows us to collect data and learn about things. You know, we learn trends like joint range of motion in hemophilia patients. A lot of this would not have been known without the efforts from the Athens. And this is an exclusively North American project. So there are a number of projects that Athens conducts. As you can see, ours is the 9th one. And this is a project that was started years ago. So I'm one of the investigators, and one of the other members that works with this group as well is Angela Wine from Michigan. And you can see the project manager there is Carol. And so the purpose of this was, as you heard before, that a lot of times the industry struggles to enroll patients in these studies. Oftentimes, if they get 30 patients on an industry trial like severe von Willebrand's, it's a huge victory because the criteria has to be fairly strict. Most of the patients can't be on a product prophylaxis before they enter it. And so we thought this would be a good way to capture some natural history data. Unfortunately, I can't show any new data at this moment. If the meeting was a little bit later, we could have. Currently, there's some data that's under review with Takeda, and I also want to thank them for sponsoring the study over the years. So we're the principal investigators, and the design of the study is fairly simple, and the aim is simple. We wanted to characterize the phenotype and treatment regimens in which people are on what we call clinically severe von Willebrand's. And so whatever your doctors are prescribing, we're not telling them what to do. If they're on every day, once every three weeks, whatever they're doing, we want to describe that and see if there's benefit in that. This is a prospective observational study. The goal is to enroll 120 to 130 patients from over 25 centers. And we define type 3 sort of severe as sort of loosely, because we wanted to make sure we captured all those patients that may have not met the definition of the traditional severe von Willebrand's. So type 3, of course. Type 1 if you have a level less than or equal to 30 on 2 different occasions. Specifically, hopefully focusing on one of the newer assays. And then if you're a patient that requires recurrent use or on prophylaxis and you don't have those levels, then we also want to capture that data. And then we did standard testing, we did genetic analysis in Wisconsin, we did inhibitor testing there as well, and we did bleeding assessment through the bleeding tool, and if there was menstrual bleeding, then we captured that through the PVAC. So this is the data that was collected. I can say was now because enrollment is, I believe, officially completed. We're going to continue to follow the patients that enrolled recently. And so we wanted to capture data at baseline and every 6 months, and we wanted to capture a number of quality of life questionnaires so we can sort of get an understanding of what the quality of life and what the burden of the disease is. And so this is a little bit older data, but at the time we had 81 patients. Not surprisingly, in the United States, we gathered most of these patients were Caucasian, a little over half were female, and we had people as young as newborns and as old as 75 plus years of age. Most of the patients, as expected, had bleeding events before age 10, and most of them, a small number, 20%, had bleeding before their first birthday. Not surprisingly, we're trying to clean up the data on surgeries. Everybody knows nosebleeds is a problem. Nasal cautery is the most common in dental extractions. And then colonoscopy, endoscopy, and dental extractions seem to be the ones that people struggle with regards to bleed control. Not surprisingly, type 3 is relatively uncommon. You know this. So most of the patients were severe type 1s. We had a lot of type 2As and then a smaller number of type 3s in the study here. And you can see here the number of patients that are on prophylaxis. At one point, we decided that it was on demand, but we wanted to capture a lot of prophy patients. And all the on-demand patients enrolled very early, and then we closed it to them. You can see the bleeding score, which indicates a higher score of more bleeding. It was on average around 10, but it ranged, as you can see there, depending on the age. And you can see the number of patients there we had on prophylaxis at the time. We had about 30 that were on some form of prophylaxis. We're trying to analyze those that are using it for heavy menstrual bleeding prophylaxis because some of the regimens are a little bit different and a little unique. And you can see the average PVAC score, typically greater than 185 is considered significant, or 150. And you can see the score on average is 247 of the ones that did collect that data. So one of the things that was really interesting is if you look at the studies performed in Von Wende and in Willate, the typical dosing is much lower than what's actually used in real life. And probably, we were talking about this before, probably because we didn't know what dose to use, so people kind of come up with the dose that they use for replacement for major bleeding. So the dosing that's being used in the real world is almost double the dose that's used on the trials. And so obviously we'll need to figure out why that is. And there's some patients that may need that and some that may not need such a high dose. It may actually be beneficial because the higher the dose, the more volume, so the more difficult the infusion. But for example, on the Von Wende and the Willate trials, on average, most people were dosing somewhere between 20 to 30 units per kilo, 2 to 3 times a week, most of them twice a week. And so, so it'd be interesting to kind of look at this more. And of course, a lot of this was before the label change. And so there were, all of this was quote unquote off label. We reported adverse events. There's the UHAS system. I'm not going to go through all of that. We're reporting that during the study. We targeted 130, and then we decided that we needed to have more prophylaxis patients because there were a large number of on-demand. We do care about on-demand patients, but obviously the focus of the study was on prophy. And so, we wanted to get to about 120 to 130. The pandemic definitely made it a big struggle to enroll patients for 2 straight years. So we got to 107 at the end of the study, so I still think it's a good number. We may end up with like 108, 109 or so, depending on who enrolled this month at what center. But there were 26 sites, 2 adverse events that were not study related. We didn't report any thrombotic events in the patients that we're seeing. And you can see the enrollment. For a while, we were doing pretty good, and then, of course, the pandemic wreaked havoc and got us behind on enrollment. And so you can see there, we'll probably end up with maybe 50 patients on prophylaxis, so I think that's still a pretty good number. We're going to follow the patients that just most recently enrolled. So one of the last 2 slides, people are saying, well, what's next? Because the study is now close to enrollment. What was really interesting is we did get genetic data on the majority of the patients. There's still some patients trying to come in to get that data. We're still trying to sort that out. We actually tested all these patients for inhibitors, and only one of them that we already knew had an inhibitor was positive. So we didn't find a very high rates. And I know the CDC recommends it, but they don't even have a test at their center for it, so it has to be sent to Wisconsin. So one of the things that James O'Donnell, I don't know if he's given a talk or not, I just got this meeting just a short while ago. We wanted to resurrect this idea of the prophylaxis network. So this was an initiative, Dr. Eric Berntorp from Sweden, and Tom Abshire, who was in Atlanta and then Wisconsin, started out. And so we wanted to bring this network back into it. Initially, I think most of the funding was from CSL, and right now we're in the sort of fundraising part. We do have some funding from Takeda and Octapharma. And so we really want to look at a couple of different things: prophylaxis, the modifiers of BWV. I know James is going to be looking at a lot of this. Looking at long-term joint outcomes, bone health, and quality of life. And I think there's a few things about doing pharmacokinetics and personalized dosing. It's really interesting in hemophilia, severe hemophilia, everybody starts at the same level, right? 0%. And so there's a lot of work over the years on personalized dosing. And most of the von Willebrand patients in here, there's very few that have the exact same level in this room, even with the same type. And so I think we talk about this, but everybody gives around the same dose, no matter what subtype. And I think there probably is something that we need to learn about. And it could be why some people fail drugs because maybe the dose just wasn't adequate. So that's one of the things we're going to do pharmacokinetic-wise. These are the aims. It's a non-branded platform. We're hoping to be able to build a network and be able to do some of these trials, because you've heard before, it's very difficult to do trials, very expensive. Smaller centers just aren't often equipped to be able to do this, and so it becomes a problem. We're going to be working on common data elements to make sure we're using the same language. Right now, there's an effort being done looking at core outcomes at NHF. We're going to look at pharmacokinetics, specifically POP-PK. There's the WAPS Hemo, if anybody's used that in hemophilia, and we're trying to get that effort in von Willebrand's. And then the last here, we want to look at personalized dosing. I think we just use the same dose for everybody all the time, and I think we certainly can do better. And then we want to look at the role of this on joint and bone health. We have a claims data set in which bony and joint outcomes seem to be worse off in patients with von Willebrand's compared to the general population. And it can't all be attributed to factor VIII, because most patients with mild von Willebrand's have normal factor VIII levels. And so we're just trying to understand a little bit of that more. We're still trying to work on this idea of a biorepository. That gets very complicated between centers, as James knows, and so we'll try to work that out and see if we can do this. But they're working on a novel diagnostic assay at Emory, and so obviously we'd like to be able to offer that to others as well, and maybe it can be part of the standard testing regimen. So that's all I have for today, so thank you very much for letting me talk.
Thank you for being here. I appreciate it. Yeah, we'll do questions at the end. So I do have to note that this was a rough weekend for a lot of our faculty in terms of personal schedules, other commitments that they had. And I know you haven't seen everyone throughout the weekend as you normally do, but Dr. Sidonio really jumped through hoops to be able to spend today and tomorrow morning with us. Truly appreciate it. Some of the speakers you're going to be seeing next coming up are crossing the sea to be here. I know you've met a few of them already during the conference. And when you think about it, they're coming here. They're coming here to talk to you all, right? I mean, what passion, what care. And I just want you, just a round of applause for the logistics for these people. All right, so Dr. Sidonio segued right away for me into our next speaker is Professor James O'Donnell, live from Ireland, which is nice for me. I'm a Macaulay originally, so thank you very much for being here, and the floor is yours.
Thank you very much, Juliet. It's very nice to be here and to support what I think is a very important initiative. So I'm a clinician scientist. I spend half of my time looking after patients with bleeding disorders in Dublin, and the other half of my time looking after a research lab. I'm going to talk to you about the research that we've been doing over the past almost 20 years now, which is somewhat frightening in 10 minutes. So these are some disclosures. So one of the things that we've done a lot of work on over recent years is something called the low von Willebrand factor Irish cohort study, or LOVIC study. So this is something that I set up back in 2015, and it was to recruit patients who had mild to moderate von Willebrand disease, so different to obviously what this meeting is focused on. And we prospectively have followed those patients over 15 years now almost. And we've published a whole lot of papers out of this study. I guess the key message from all of this is that some people who have mild to moderate reductions in von Willebrand factor levels actually have very significant bleeding. So when we're talking about severe von Willebrand disease, I think we have to be very clear about what we're talking about, because some people with mild to moderate reductions bleed a lot. All those papers are online if anyone wants to have a look at some of them. Leading on from the Lovik study, we got involved in the Zimmerman program that you have heard about from Bob Montgomery already. So this is funded by the NIH. Bob's been leading it for more than 15 years now, and what has been really a monumental work for the field. This is the biggest von Willebrand disease study in the world. And I'm delighted that one of the flags there now, as well as the United States and Canada, is Little Ireland. So that's at least some recognition of all the work we've done in 20 years. So moving on to severe von Willebrand disease research, one of the key questions we've been interested in Dublin is, how does von Willebrand factor get cleared from the blood? Normally, von Willebrand factor, as you've all heard over the course of the last day and a half, is made in endothelial cells, and then the endothelial cells pump it out into the blood, and it circulates in the blood for maybe 12 hours before it gets cleared, and it's cleared by the liver. So we've known that for quite a while. Previous studies from Dr. Lenting, who's going to speak in a moment, and from France, has shown that there are special cells in the liver called macrophages, and that these macrophages are able to gobble up von Willebrand factor as it's passing by. So this is one of the key mechanisms that determines how long von Willebrand factor lasts in the blood for. And in the last 10 years leading on from that, we've identified a bunch of receptors on macrophages. So these are receptors on the surface of the cell that can bind to von Willebrand factor. And there are a number of them there, as you can see. So why is all that science important? Well, if we understand how von Willebrand factor gets cleared normally, that offers us the opportunity to develop longer-acting von Willebrand factor therapies, which is obviously something that we're all striving for. This has been something that's happened in haemophilia already, as you all know, but of course, as ever, von Willebrand factor is lagging behind. There are a few therapies out there, and you'll probably hear more from Peter Lenting in a little while, that already can be used to prolong von Willebrand factor survival in the blood. One of them is an Aptamer, a small molecule. It's got the name BT200. And so the company who developed this small molecule as a therapeutic, we're actually developing a therapeutic for use in patients who had stroke. But by chance they discovered that when they put it into people, that it actually doubled or trebled their von Willebrand factor levels. So not terribly useful in stroke, but that's just about the last thing you would like to do. But perhaps useful in the context of von Willebrand disease, and in particular in subtypes of von Willebrand disease, like type 2B von Willebrand disease, where this small molecule can increase von Willebrand factor levels 3 or 4-fold. What's interesting about this molecule, although the pharma company have developed it and are moving ahead with clinical trials, is that they have no idea how it's working. So they don't know how it's increasing von Willebrand factor levels. They discovered it by accident. And so work that we've been doing in Dublin is to try and work out how exactly this small molecule is increasing von Willebrand factor levels. And we have data that we presented just last month in Montreal showing that this small molecule BT200 binds to a specific region of von Willebrand factor, and it turns out that that specific region is key for regulating macrophage clearance. So this insight gives us an opportunity to develop things that are targeted towards that actual key spot. Other long-acting therapies for type 3 von Willebrand disease, well, obviously in haemophilia you probably all have heard that you can pegylate the factor VIII molecule. That will prolong the half-life. And so you can also pegylate von Willebrand factor. The problem is that you have to pegylate it in a site that doesn't interfere with its biological function. So we have done some work in Dublin looking at targeted pegylation of von Willebrand factor. And the final way that you can develop a long-acting von Willebrand factor therapy is by accident again, I guess. So Bombendi, that you have heard about already at the meeting, has a longer half-life than plasma-derived von von Willebrand factor, 20 hours may be compared to 14 hours on average. Again, we don't know why that's the case. We have been doing some work in Dublin. As you can see there, the Bonvendi doesn't just last longer in people, it also lasts longer in mice. And it looks like, depending on how the VWF is made, you can change the sugar structures and that will affect how long it survives. So there are a number of ways to prolong the half-life of a Willebrand factor, and you're going to hear more from Peter in a little while. A key area of research for us in the last 5 years has been the idea that von Willebrand factor isn't only important for blood clotting, that it has other biological functions that we don't really understand very well. So these have all come to light really in the last 5 to 10 years. So as well as being important in blood clotting, which you've heard a lot about over the last day and a half, von Willebrand factor is also important in inflammation at sites of injury, for example. It's also important in the development of small blood vessels called angiogenesis. And it's also important in wound healing. And those other functions of von Willebrand factor have also been shown to be important in different diseases. So as well as von Willebrand disease, von Willebrand factor has been shown to be important in sickle cell disease, in cerebral malaria, and most recently in acute and long COVID. So VWF plays other roles apart from just blood clotting. Why is that important to a severe von Willebrand disease meeting? Well, it's important because those other functions of von Willebrand factor might be contributing to the bleeding in patients with von Willebrand disease. So for example, if we think about heavy menstrual bleeding, which is a really common problem, every month ladies are bleeding, then they have a round of inflammation and healing, and then they have a round of angiogenesis before they have the bleeding the following month again. So if von Willebrand factor has the potential to affect inflammation, angiogenesis, and wound healing, as well as bleeding, you can see that von Willebrand factor can impact on multiple parts of that cycle. So that's something that we're working a lot on at the moment. On the final couple of slides, I'm just going to talk about prophylaxis. So Robert's already highlighted this for you. That I think there's a general feeling amongst many people in the community that prophylaxis in patients with severe von Willebrand disease is really a critical unmet need. Robert, Bob and I were all involved in writing the ASH guidelines, and I think everyone at the meeting collectively felt that prophylaxis in von Willebrand disease is probably 50 years behind where it needs to be. There are many people who should be on prophylaxis globally who are not. So the ASH guidelines kind of touched upon this with the idea that, for patients with von Willebrand disease, with severe von Willebrand, with severe bleeding, that they should be considered for prophylaxis. I don't think that's really happening terribly well at the moment. There's a couple of things to touch upon from the guideline. First of all, you can see that the guideline says suggests rather than recommends. And the reason that the guideline says suggests is that we have very poor evidence. So this has been talked about in the previous session, actually. Mr. talked about this. So there are key unanswered questions about using prophylaxis in patients with von Willebrand disease, like how to choose the best patients, as Robert mentioned a moment ago, what dose we should be using, what the optimal trough level for von Willebrand factor should be, whether that trough level should be different for people who have got joint bleeding as opposed to people who have got, for example, heavy periods, and so on and so on. And so if we really want to get prophylaxis used optimally in von Willebrand disease, it's imperative collectively that we collect the data that is going to underpin those decisions. And I think, I would urge this group. This is certainly an area where I think patient driving the agenda is going to be very important, because my feeling is that right across Europe and North America there are many patients with von Willebrand disease who are bleeding who should be on prophylaxis. And as patients with von Willebrand disease are living longer now, I think that issue is going to become more and more important, because the angiodysplasia and the gut bleeding tends to become more evident as people get older, and so the need for prophylaxis may get more and more. So Robert's already mentioned that's why we really think that we need to reinvigorate the idea of having a global VWD prophylaxis network, because we desperately need this data. And with that, I'm just going to acknowledge all the people in the National Coagulation Centre in Dublin who are doing all of this work, and I should also acknowledge the funders of the work, particularly Science Foundation Ireland, the NIH, and the Wellcome Trust. And then finally, the Irish Haemophilia Society, who are the Irish patient organisation, led by Brian O'Mahony, who many of you will know, have kind of been key in driving all of that in Ireland. And so I'm going to leave it there, but I'll be happy to answer any questions.
Thank you very much. That was super interesting. I know you touched upon a lot of things, but a lot of them that are very pertinent to the lives of these people, so thank you. And next up, we have Dr. Jordan Shabib with a rather fishy presentation, I hear. Very corny, I know.
Right, so I'm going to talk to you about our fish model. I'm going to spend most of the time introducing you to that. You can see the fish there. I find it very soothing to watch this. And so we're going to have to move on from it. And most of our work so far has unfortunately not been on von Willebrand disease. So I'm going to spend most of the time introducing you to the model and with a little bit of the progress we've made in von Willebrand disease. And so what my lab is primarily interested in, stemmed out of work I did in my postdoctoral fellowship on von Willebrand disease, is in genetic modifiers. And when it comes to genetic diseases, there's a primary disease mutation, but we have 20,000 genes. So we have these other genes that variation in them can affect how severe a phenotype our clinical symptoms are from a primary disease mutation. And of course, we're talking about von Willebrand factor. Now this is a pedigree that's actually not von Willebrand disease, but I'm going to use it. It's something called factor V Leiden, which is the opposite of bleeding. But let's pretend it's von Willebrand disease, because I think it's helpful. So if you look here, you can see that 15 individuals are shaded on the right, and so we'll say they have a von Willebrand disease mutation. But only 5 of them are also shaded on the left, meaning that they have more severe bleeding symptoms than the others. And you've heard about this a couple of times already, right? So there might be some individuals who inherit genes that are protective, or others who inherit genes that make them more susceptible to bleeding. And if we could get at these genes and understand them, we might be able to more accurately predict who's going to be at risk of bleeding, and also tailor therapy based on those modifier genes. So the power of genetic studies is to have very large pedigrees. To get at these modifiers is a big challenge. And it's nice if you can have a single pedigree. And human pedigrees are relatively small. They can be manipulated. Mouse pedigrees are very large, and actually they can be technically infinite if you use certain kinds of mice, but they get very expensive. And we use zebrafish because a single mating pair can produce hundreds of offspring and do that on a weekly basis. It enables us to make very large pedigrees. Of course, it's important to know zebrafish are vertebrate organisms like mammals, and the genome has been sequenced, and we've seen that they have basically all coagulation factors at the genetic level, and then functionally, we and others have shown conservation of that. And if you look at the bottom of the slide, you can see their life cycle. They start with a single cell embryo that grows into a free-swimming larva by 3 days of life, and that larva has a beating heart and circulating blood and an intact clotting system. We can keep about 100 of these in a petri dish, which is about 10 centimeters in diameter. And we don't have to feed them for the first week, so it's very easy to care for them. We can put them into these multi-well plates. I don't know if you can see there's a single larva in every well, and then we can test a different drug in each well to see if it will treat our disease of interest. So just a brief review of the coagulation cascade. This is a model of a blood vessel. You can see there are endothelial cells lining the blood vessel, and bleeding occurs when there's damage, and you get hemorrhage, red blood cells leak out. And this is followed by platelets and von Willebrand factor, which is known as primary hemostasis or primary clotting. And I just want to make a side note about zebrafish. So mammals have red blood cells and platelets, you may know this, that don't have nuclei. Most cells have nuclei, which contains DNA. Zebrafish actually, their platelets are in the center there, those blue cells. Those are called thrombocytes. They do have nuclei, and the red blood cells surrounding them in that picture also have nuclei. So that may seem very strange, but it's actually mammals that are strange, because if you look at other organisms like reptiles and birds and amphibians and fish, they all have these nucleated cells instead. Only mammals have the cells without nuclei. Anyway, the next step is the coagulation cascade. And in that mess of factors there, you might pick out factor VIII and factor IX. And then that leads eventually to the production of a fibrin clot, which is secondary hemostasis or secondary clotting. And there are natural anticoagulant proteins, and you heard a little bit about protein S this morning, and I'll mention briefly antithrombin, that keep things in check so you don't have clotting when you don't want it to happen. And this is all a delicate balance between bleeding and clotting. So we've used genome editing with things like CRISPR, which we've talked about a little bit over the meeting. We've used those to make mutations, or what we call knockouts, of each one of these genes that I've shown here, and separately, not all together. But we have a model of basically every coagulation disorder. Just as a side note, something about their blood that I just think is fun to show. We did this project with John Weisel at the University of Philadelphia. He does these beautiful scanning electron microscopy images. And what we do is we take whole blood, kind of crack it open, or let it clot, crack it open, and then look at it by microscopy. And he had done this before with human and mouse blood, and there's one of these is zebrafish, and you can't tell the difference. They pack very tightly, and they form, those are all red blood cells that are packed tightly, and those are called polyhedrocytes. And we thought zebrafish would look different because of those nuclei in the cells I told you about, but this is the fish, this is the mouse, and that's the human, and you can't tell the difference. Always a gift for the host. So one of the ways we study clotting is we use a laser to injure the endothelium in the venous or arterial circulation, and that leads to the formation of a clot. And this is what it looks like in the venous system. So right there, that little blip there, you might have seen it at the tip of the arrow, that was the laser hitting, and you'll see a clot growing, and it will eventually obstruct flow. And we can also, because zebrafish are transparent, we can, sorry, I want to start this other movie because it's long. Look at the bottom right for now. We can tag molecules like fibrinogen that makes the fibrin clot with GFP, green fluorescent protein, or we can express it in cells so it fluoresces. So on the right, you see that in the venous circulation, the clots are fibrin-rich. And on the left, and hopefully it's going to show up soon, I had to replace the movie and I forgot to cut it down. These are green fluorescent thrombocytes, the platelet equivalent, and this is in the arterial circulation, and you see we get primarily thrombocyte or platelet-like rich clots. And that's, again, similar to what you see in the human arterial circulation. Another way we can look at this is sometimes these fibrinogen GFP fish will get spontaneous blood clots. What I showed you was with the laser. This is spontaneous, and you can see in the venous vessel there these green fluorescent clots. And we have a scoring system where we simply grade it by somebody who doesn't know the conditions, and they just blindly grade what they see, and we can get grade 0 of no clots up to grade 3 with lots of clots. So those are the tools we use, and I'll show you how we use some of them. But we have made knockouts this is the coagulation cascade, and I'm going to show you the extrinsic pathway and the common pathway. We've made knockouts of those, and it's very interesting because knockouts of those in mice, which is similar to what we probably see in humans, is that complete loss of these factors is not compatible with life. So in the mouse, they die during pregnancy, or they die shortly after birth. But in the fish, they actually survive. So you can see here in this graph, we see the percentage of fish that are surviving. And you can see the red curve is fish without factor 10, for example, and the other ones all look very similar. And you see that dropping off. But you see where the adult period starts. This is after adulthood. So they are living into adulthood with this severe clotting disorder. And then they eventually do die of bleeding. They start to develop hemorrhage. And by 6 months of life, they're all dead. But it's just very interesting that they can survive this. And if we can understand that, maybe we can come up with new therapies. So let's talk about VWF and factor VIII. So we went ahead and we made CRISPR knockouts of those. Our von Willebrand factor knockout is a model of type 3 von Willebrand disease. I'm going to talk about factor VIII first, and it gets a little complicated. We use that green fluorescent fibrinogen tag that you can see in the lower left to look at spontaneous clotting. And actually, I'm just going to talk about this. So what we had to do, when we first looked at factor VIII knockouts, a model of hemophilia A, they had no symptoms. We did our laser injury, we looked at other things, and they survive to a year of age, and a few of them die, a small percentage, but they survive really well.
So we had to actually mate them into this antithrombin knockout, which is one of those anticoagulants, and I don't want to get too stuck in that. I'm happy to talk about that later. But if you just look at this graph, the first bar there with all the green, that is factor VIII, normal factor VIII, and they clot a lot. So the clotting is normal. The next one, they're missing one copy of factor VIII. It's not on the X chromosome in fish. They're missing one copy, and they have less clotting. And you can see when there's no factor VIII, there's almost no clotting. Okay, so factor VIII has a role in clotting. We were like, thank God. So I'm just going to skip over this in the interest of time, right? We're talking about VWF carrying factor VIII, and if we skip over to that same thing for von Willebrand factor, look at it, it's all green. So with or without von Willebrand factor, we get lots and lots of green, right? And that's very different than factor VIII. We would have thought that loss, if you completely take out von Willebrand factor, that factor VIII levels would go down very low, right? A lot of you know that, you have that. And that we would see a similar effect to that factor VIII graph on the right, but we don't. So it suggests a couple of things. So to summarize this, we have used genome editing to produce knockouts, and right, the key thing is they're different, but they're similar. All right, so they have severe clotting defects, the other factors, but they live longer. So it's an opportunity to see what are these differences, and if we can understand that, we can maybe make better differences for humans. And then when it comes to von Willebrand disease, it appears that von Willebrand factor in fish might not be carrying factor VIII. That factor VIII has found some way in fish to stabilize itself without von Willebrand factor. And if we can understand that, that could be helpful for von Willebrand disease and for hemophilia. And also, von Willebrand factor doesn't seem to be relevant for platelet binding, for thrombocytes. When we do that laser injury with the thrombocytes, they adhere just fine. So if we can understand how that's happening, then we can maybe develop some new therapies. So I found this up in northern Michigan after living here for 20 years. I only found this a couple of years ago. There's a Jordan River fish hatchery. So I would say thank you for coming to my fish hatchery. This is my group, and these are called Casper zebrafish that have no pigment. All right, thank you very much.
Thank you. Thank you very much, Dr. Shavit. It's funny, I can look around the faces and I can just see people are dying to ask questions at the end of all this. And by the way, I am not officially introducing all these people. If I actually stood here and told you all their credentials and their doctorates and their this, that, and this, the session would be over before I got done introducing them. But please note in your agenda booklets, you have the full biographies of all these wonderful people presenting, so feel free to take a look at that. Next up, we have Gay Paris with Dr. Peter Lenting from Paris, France.
Hello, everybody. I'm very happy to be here, and one reason for that is that, already for quite some years, actually pretty regularly in our lab, we also organize patient meetings. That means we invite patients that are associated with the French Hemophilia Association, and we spend the whole day with them, or usually it's now 2 days, showing what we are doing, and above all, we do a lot of discussions with them to understand from them better what they actually, how they live their life with the disease, and what they actually expect from research to come forward in the next coming years. And I have to say, until quite a number of years ago, we were focusing mostly on hemophilia. And during those meetings, how do I go to the next slide? You see, yeah, there it is. So when we were having those meetings, I mean, hemophilia patients, they were very happy because there were a lot of new therapeutics being developed, Hemlibra, gene therapy, BIF01 or AFA, as it is now known. And the vulnerable disease patients that were with them, they said, okay, that's all nice for them, but what's in it for us? Because it's now already for 30 years that we are having the same kind of treatments, concentrates, antifibrinolytics, desmopressin. Is there not something else for us in the pipeline? And at that time, and I'm now talking about 8 years ago, actually there was nothing. And for us, that was actually a sign to say, okay, maybe we should change a bit gears and try to look a bit more in what can we do for also for the Van disease patients. So maybe one reason why nothing has happened over all those years, I mean, there are plenty of different reasons, but I think one of them is that for the clinicians, and it's not I don't want to bring down the clinicians, not at all, but for them, the job is to stop the patient from bleeding. And with the things that are there, they can stop the bleedings in most of the cases. But when you're then talking with the patients, they say, yeah, but there's basically no prophylaxis, so I don't want to go to a restaurant because I'm afraid to get nosebleeds, or every morning when I wake up there is blood on my pillow, or when I have bruises, I don't want to go to the beach, things like that. So for them, it was more than just stopping the bleed. It was for them a bit of a reduction in quality of life. So from that moment, they said, okay, we want to do something. So we have started to do a lot of things in our lab, and probably only a few of them will be successful, and most of them will not be successful, but because that is how research works. So I'm not able to discuss all the things that we are doing in our lab, and certainly I don't have time to go in detail about all the fundamental aspects that we are doing, but I want to give a bit of an update of what we are trying to do in terms of therapeutic development. So I have tried to separate it in three pipelines, one that is based on antibodies. We have heard an antibody this morning about protein S. It's the same type of molecule, but against other targets. You can try to correct genetic defects with CRISPR-Cas9, with transposon-based therapy, with siRNA, and with gene therapy, and I will say a few things about that, but not so much. And the latest thing on the tree of new developments are synthetic nanoparticles. So I will give a few options that there are four that I will discuss in more detail. So the first one is what we call a bispecific nanobody. A nanobody is a very small antibody, about 1/10 of the size, but it works as good as a normal antibody that we actually use to increase endogenous levels of VWF. Well, how does that work? So normally when you get VWF, concentration, you infuse, it has a half-life of 13 hours, so you get peaks and you get truffles. So it's because Van Willebrand factor has a relatively short half-life of 12 to 18 hours. But if you now look at other proteins in the circulation, like for instance albumin, that has a half-life of 3 weeks. So that's much longer. So we were thinking, can we not use that idea of albumin that in one way or another that we can couple it to your VWF that's already there or that is going to be infused. And so actually we're going to recycle your VWF by using albumin. Well, how does that work? Well, you take 2 different nanobodies, 2 different very little antibodies, one that is binding to VWF and another one that is binding to albumin. Like that, you make a kind of a bridge between those 2 proteins. And if there is enough of the albumin bound to VWF, then it will go recycle. It's going to be recycled with your albumin. Well, does that work? Well, I'm not a clinician. I'm a biochemist, so I don't treat patients and all that, but I treat a lot of mice. And so we have developed specific mouse models that are representative for severe type 1. So those mice, they have about 10% VWF. And if we give 1 shot of that nanobody subcutaneously, then for at least for 10 days, the VWF levels are being doubled. Yeah, so that looks pretty good. And when we use a control nanobody, it doesn't work. When we do a bleeding test, then it stops the bleeding, etc. Also, the factor VIII levels are going up the same way. Yeah, so you get really a very important increase in the VWF and factor VIII levels when you give just 1 shot of this nanobody in these mice for at least 10 days, almost for 2 weeks. So that looks pretty good. So we have done a lot of work on that, and I will not go into detail. So we have humanized the nanobody. It has been tested in different animal models, etc., etc. And actually, the data are so promising that now it has been licensed to a US-based pharma. Right now, I cannot say which one, who is going to develop the molecule for the clinic. And we hope that in 2025, we can start the clinical trials with this molecule. So this is a molecule that is of interest for patients with low VWF levels, and that can eventually be used for prophylactic treatment with a simple fortnightly subcutaneous injection of the molecule. Again, it's all in preliminary. Everything I will present is in very early stage. It needs to go through a lot of steps in order to get into the clinical trials and eventually to get approval. So another thing that is a bit hot in terms of discussions lately are antibodies that can mimic factor VIII activity. And why is that of interest? Well, as has been mentioned quite a number of times, when you have reduced VWF levels, also your factor VIII levels are being low. And actually what we don't know is that when a patient with type 3 VWD, for instance, when they start to bleed, is that because the VWF is not there, or is it because the factor VIII is not there, or both? We don't know that. So there has been some clinical trials where there were actually patients getting surgery. I think that's in the next slide. Yeah. So there have been some anecdotal studies done where patients with VWD type 3, were getting surgery. Those patients had antibodies against VWF, so they were not being able to be treated with VWF concentrates. So they were giving continuous infusions of factor VIII. Why do you need to give continuous infusions? The half-life of factor VIII is so short that it goes out very quickly if there is no VWF. So like that, you can keep the factor VIII levels pretty high up. And during that surgery, the presence of factor VIII prevented much of the bleedings in these patients. So that gives an idea that under some conditions, that if you correct the factor VIII, you can at least try to prevent or stop some of the bleedings that are in those patients. So for prophylactic treatment, factor VIII is not an option because the half-life is so short, but nowadays there is something else, and that is the very well-known Hemlibra of emicizumab. And also there, that has been tested already in a number of patients. If you give those patients emicizumab in type 3 patients, then there are now about 10 patients case reports that have been reported. Those patients, they have very much reduced bleedings. They don't have no bleedings. Under some conditions, they can have some bleedings for which they need VWF. So that could be an option for some cases to reduce spontaneous, especially joint bleeds in those patients. Be aware, and that is probably also true for the anti-protein S antibody that was discussed this morning from Vega. Those antibodies, they correct the factor VIII deficiency. They don't correct the VWF deficiency. So beware of that. Yeah? But it could be an option to reduce a lot of joint damage in patients with severe type 3. And right now, there is a first clinical trial that has been initiated here in the US, which is registered at ClinGov. Our own lab is we are working with Roche to test this emicizumab in other subtypes, because we are not sure whether emicizumab will also work in a type 2A or a type 2B or anything. You know, that's not very easy to do. So, and I think in the next years there will be more clinical trials to see if emicizumab can be used in some instances for VWD. So now go to synthetic nanoparticles. Well, that sounds very science fiction and all that, but you know, those lipid nanoparticles, they have been used now in billions of people because they were part of the COVID vaccination. So those molecules, they are very well known, they are safe, and they can be used. So how can we use those lipid nanoparticles for VWD? That's the big issue. Well, apart from being a chaperone protein for factor VIII, actually the foremost role of VWF is to recruit platelets if there is an injury in the vessel wall. And how is that doing that? Well, I've tried to illustrate that with this airplane that has to land on those big ships on the sea, on those carriers. And with the plane being the platelet, the ship being the vessel wall, and then VWF is that little hook that keeps the plane on the boat. Yeah, so if you have a nanoparticle, what you need to do is actually try to make an anchor for the airplane, for the platelets, and an anchor for the vessel wall, the ship. So actually that's something you can do, and actually that has been done by a group here in the US that is from Sengupta who has developed these synthetic platelets, what we call them, the platelet mimetics. He even has a startup who is developing that in collaboration with the US Army for all kinds of other things, for traumatic injury bleedings. And we were thought, in discussing with him, we said, actually we could try using those things in mice, because they have an anchor for platelets and they have an anchor for the vessel wall. So why should it not work? So that's what we tried to do with the familial factor deficient mice. So here is something that we did in vitro. We took the blood from those mice, we spiked it with those syntoplates, and then we perfused it over a collagen surface, some kind of vessel wall on the very high speed. And actually what you can see that if you use those syntoplates in mice, then you can actually, those big white spots that are the thrombi, these platelets that are accumulating at the surface. Well, that's all nice in vitro, of course. Does it also work in the mice? Actually, it does work pretty good. If you compare to wild-type mice, it's not as good as full VWF, but it's really strongly reducing the bleeding in these mice. And actually, the advantage of those syntoplates is that you can keep them for 6 months at room temperature. You can lyophilize them very easily. They are very stable. And they have a half-life that is about 4 times as long as VWF. So they are not there yet. I think we need to do much more work to improve it. But I think it could be how to say it, it's an early start in which we can try to see if those type of molecules can actually be used for the treatment of VWD. And we already know that also in type 2B, those molecules work actually pretty okay. Yeah, not as good as in type 3, so we have to do a lot of engineering on those platelet mimetics to make them better. And actually we can try to optimize them for each subtype, for type 2A, type 2B, type 2M, etc., etc. So then what is left is gene therapy. So that is a bit of the holy grail for treatment of VWD, of course. I think yesterday there was already a presentation on gene therapy. I don't know what was said, so I'll just go blank from that. So in the last several years, our lab has already been working on gene therapy. That was not very successful because we were able to express VWF, but levels were very low. That is not a failure. That is actually teaching us a lot on where we can try to improve it. And I think we are now at the stage, and I cannot show you any data right now, I'm not allowed, but it has allowed us to go again a few steps further on, and we are actually initiating a collaboration again with a US-based pharma in the next 2 years to make hopefully a bit bigger steps forward to do this. So that's something that will not be there in the next 5 years. Don't think that, but I think in the longer term, I'm very much convinced that we will be able to get up with something for gene therapy for VWD. So after many years of non-development, I think there are now a lot of things going on. You saw the slide from my lab, from our lab. That's not including all the things that James has been telling you and the person from Vega Therapeutics this morning. There are quite some things going on. I think that's good because that will allow the development of a number of choices later on. But again, things are early development and things can fail. That is as simple as it is. Well, I think I'll leave it as this because there are other speakers too. Thank you very much for your attention.
Thank you, Dr. Lenting. You don't have to run, it's okay. All right. Our next speaker, Dr. Tung Nguyen from here in Florida. A lot of you know him with us since the beginning to tell us about a project that the foundation is sponsoring.
So, yeah, thank you. So this is a project that is sponsored by the VWD Connect Foundation through an unrestricted grant by Takeda, and we'd like to acknowledge and thank them for that funding as well. So, but it's a project that I think is going to have a major impact for this community in particular, and going to fundamentally kind of impact kind of everything that you guys have heard so far. And the project, what we'd like to do is really kind of develop a agreed to unified definition of what severe von Willebrand's disease is. Fundamental to what this foundation does, which is to serve the severe VWD community. So, von Willebrand's disease, we do know, is a condition that, patients who have it don't have normal von Willebrand's factor in their blood, and that leads to just the excess of bleeding. And we do know that there are many types of von Willebrand's disease which we can categorize based upon our guidelines and classification systems. And those classification systems do recognize that there are a subset of these patients who are severe in their nature. I think long-standing, we know that type 3s are the types typically that have the most frequent and most severe prolonged bleeding. And over the years and through a lot of actually what we've done here through the foundation, we know that other types can have severe bleeding as well. You've heard already type 1s and the type 2s. So, the point is, I think severe VWD is recognized, although, what encompasses it, really isn't well and clearly defined. Another recognition is, kind of based upon the guidelines, the most recent von Willebrand's disease guidelines, do recognize that there are patients who have more severe bleeding than others, and they recognize that those patients should be treated, on a different course. Specifically, patients should be suggested to consider whether or not prophylaxis could benefit. And so that's kind of what we want to do is kind of develop this definition, and aside from kind of impacting who would benefit the most from those guideline recommendations, I think having a unified, agreed-to definition by the scientific and the VWD community, can also kind of help us impact all these previous lectures that you guys have heard regarding kind of these projects and applying them to the severe VWD population. I don't know if we want to move forward with all of these studies and not have a well-defined population to apply it to. We know that if we don't develop these definitions as some of the more costly, for example, therapies that develop, such as gene therapy, we may not be able to actually get those things, developed and or approved by insurances and by payers here in the U.S., because we may not be able to adequately demonstrate, because of a very heterogeneous population, how it impacts, kind of the health of those patients. So, the other thing that I wanted kind of to do is to also kind of lay down the groundwork that this definition isn't kind of a set in stone definition. I think as the decade of the existence of the Connect Foundation has occurred, I think we know that this is something that's a work in progress, and we will continue to learn more and more about the nature of this severe von Willebrand's disease, and we want to make sure that the definition is a work that is continually in progress. And we want to make sure that we can utilize information that we learn, build up on that, and use those information to kind of really further refine and better treat the population that's most at risk. So, if you think about kind of current definitions, there are a whole host of them that can be found, and every one of them is going to have its slight variance. And I wanted to kind of just show some examples on kind of what this discrepancy is that we're dealing with. The registry that I think everybody here has been invited to join, has a criteria for severe VWD that defines it as anybody who has a level that's less than 20%. So, and that includes, von Willebrand's antigen level, von Willebrand's activity level, factor VIII levels. So that's fairly simple, straightforward. So, if you look through, just kind of medical literature and see, kind of a definition, you can kind of see, kind of a definition that I think, you can find from various articles. This one is from 2004, and you can see that the definition in this article slightly varies from what we're using for our registry. It calls for, somebody who has had bleeding episodes, at least 2 episodes of bleeding. It calls for bleeding time, which we don't utilize anymore. That's significant. But the levels, activity using ristocetin is less than 10%, and factor VIII is less than 20%. So, slight difference. You're going to capture a slightly different, group of patients using those 2 definitions. And if you apply, even a third one, which is kind of what we have used for our terminology session, we utilize the definition that the article presented, but then we layered on top the various types that can manifest in, the type 3s in particular, but we do know that those same levels of severity can occur in type 2Bs, type 2Ns, type 2As, and type 1s, and so all the various types also exist too, to kind of add to the complexity of the definitions. So I just wanted to kind of just show those 3 kind of examples as kind of, why can't we agree to this definition? Because it's important to define, who we are. So, and this is just kind of a summary, if you really look at it, kind of some of the various sources that you can kind of find. Most of them come from various studies that have been done, and all of them kind of have various definitions. If you look at all those and summarize kind of what has been said, you'll see that, kind of at least 5 of those sources kind of tell us that type 3s should be considered severe. Symptom-wise, having hemorrhages, you can kind of see that appear in kind of 2 of the definitions. The use of factor, for bleeding, again, a couple of those kind of include that as a part of the definition. The various types, kind of, and using various factor levels, there are various amounts of definitions that include those. And probably kind of more recently, and probably as time moves on, becoming